Hello and good morning, my friends. It is so good to be here with you again. I think I missed last week, and the one before that was a recording of a live, and so it didn't happen live. So I am excited to be here with you today. And as always, I'm always going to ask you just give me a hi, a hello in the chat if you're listening, if you're with me, and let's just make sure that I'm not talking out into the void. Okay, never want to be speaking into the void. So hi, hello, welcome. I am Carice Laguerre. I'm your Mayo best friend. I've enjoyed some of the messages and emails that you guys have sent me where you guys are like, hey bestie. Thank you. I really do appreciate you all as an audience, as a community. It's good to grow and to learn with you because that's what we're doing. We're all learning and growing together. I am not some magical guru. I am somebody who has knowledge that I want to share, and you guys have equally as much knowledge that you can share with me as well. So it's so good to be here with you every single week, going live about all things myofunctional therapy. I want to keep that going, so let's keep it going. Make sure that if you are not subscribed on YouTube, you subscribe. Turn on those notifications. I go live. It's sporadic, so sometimes it's during the week, sometimes it's on a Saturday morning. It really just depends on where it fits into my week. And so that you don't miss any single live stream, make sure that you are turning on those notifications so you know when and what it will be on. Comment, that always expands the reach. Everything that you like and you feel like you've grown from, when you comment on it, that just tells the algorithm somebody else needs to see this too. And so it'll get to somebody else with similar profile, similar career, similar pattern. And it's so good to share. If you're watching this on LinkedIn, follow or connect with me. I love connecting with people. I love your messages on LinkedIn as well. So, meet me there. Happy to see you. All right. Good morning. Okay. So let's just jump in. Okay. You've identified some type of dysfunction. I didn't miss a slide, right? Okay, good. You've identified some type of dysfunction. We're going to approach this at two different perspectives. So one is from somebody who might be referring, and or because this is helpful too for patients, prospective patients who are like, what happens in a myofunctional therapy evaluation? Like, why do I even need this thing? And then we're going to approach it from like your practitioner. So I'm going to start first as somebody who is referring and identifying a dysfunction, or somebody who's online. You've been Googling and you've been getting all of your, Google University, YouTube University research about myofunctional therapy or oral dysfunction. And you've figured out that you have something wrong. You're like, oh my gosh, I'm a mouth breather. Or you find it in your chair as a dental professional and you want to refer, and you're like, I see all these things. There's tight musculature. They're orally defensive. I did my broom screener. I've done my Epworth sleepiness scale. Like, I've done all the things I know that they need myofunctional therapy. And you've figured all that out. The next step is like, well, what do I do with this information? Do I subsequently become a myofunctional therapist? If there's nobody in the area, like, who do I refer to? Where am I going to find one? How am I supposed to get these people the help that they need? And what even is the next step? That's great questions. These are all great and very valid questions. There's no standardization in the field. Dentistry is still just getting their toes wet into myofunctional therapy. So it's something that's, we're coming along, and we're going to formulate today a process and how you can kind of work your way into having that conversation. You have to understand it first so that you can have that conversation. Or what's the next step? If it's you've identified, you've self-identified, you have a problem. I know I need myofunctional therapy. What do I do? How do I get this? Well, the process is very similar for a lot of myofunctional therapists. I'm not going to say everybody does their things the same way. There are some people who do consultations. There are some people who skip that and want to go straight to an evaluation. But for the most part, from what I can see in the field, from what my peers, colleagues, and so forth have been able to kind of show and tell me, consultations are pretty common. Okay. Consultation, I think, is incredibly essential. I've done a whole live stream on the consultation process. If your process is not streamlined, like, you need to go backwards into my YouTube and find that consultation lecture. But consultations are, I find, pivotal. They have to be done because during a consultation, you really get a good background and understand if myofunctional therapy is the next best step. There's so many people who believe they need myofunctional therapy, but first they probably need to visit an airway centered dentist, airway focused orthodontist. Maybe they need to visit an ENT. Maybe they need to get some medical clearance because they have some things going on that we can't just skip over in myofunctional therapy. So going straight to evaluation for me feels like we're missing some steps for some people who could otherwise save that money. I'm a frugal friend. Okay. So anytime I can save $1, I'm going to save 20. Okay. But anytime that there is a thought about whether or not myofunctional therapy might be best, that needs to be the consultation that kind of weeds that out. Because a lot of times I have consultations and I'm like, I think it's so lovely meeting you. And absolutely, myofunctional therapy is something that can benefit you or your child or whoever I'm talking to. It can benefit you, but I need you to do this, this, this. So here are your action steps. Okay. If you're writing this down, here. And if you're not writing this down, we'll send you an email. But here's what you have to do. One, I need you to go see an ENT. I need you to get clearance if there's nothing physiologically blocking that airway space. Otherwise, we could do myo until the cows come home. We could do myo for the next 5 years, and you will never establish nasal breathing, and it'll be a waste of time and a waste of money. Or I need you to go see an orthodontist. If you don't go see that orthodontist and you don't get that expansion done and that tongue can't fit in the space, we could do myo until the cows come home, and it's going to be a waste of time and a waste of money. Like, I need you to go do this, this, that, and that. And so the consultation I find to be very pivotal. You'll get a lot of background. Where have they been struggling? How are you going to fit in? And where you might fit in as the myofunctional therapist. Evaluation now is what we're going to talk about today and kind of flesh out a little bit more. But that's more of the comprehensive, like, overview. Okay, what's going on here actively? So you've told me all the things that you've experienced, all the symptoms. You're giving me all the signs. I'm really understanding from your subjective point of view and a little bit of an objective point of view from any prior diagnosis or any other visits that you've had, whether or not myo is what you really need. And now I'm getting a better objective view with data to support what's going on, what's happening with the muscles, how is it that you're functioning, and how can we get you to where we need you to be. So I always explain in a consultation that the evaluation is for me to pinpoint where you are now and where we can realistically get to. And I think that's the big thing for the evaluation. I'm not promising the wind, the moon, the stars. Okay. You have to be realistic. You have to provide realistic outcomes. Like, what is it that we can actually anticipate to get from myofunctional therapy? It's not going to be palatal expansion. Myofunctional therapy, as far as research or even some of the clinical experience that I've had, you're getting 2, maybe 3 millimeters. That's nothing in the grand scheme of like transverse width. AP, even less, 1 to 2, if even you get any movement along that maxillary arch, particularly within adults. So I'm going to say that, I wouldn't have that as a realistic goal unless I'm working with somebody who's very young. And then perhaps maybe I could see a little bit more of it changing the trajectory of growth. Then maybe if I find a good article or a bit of research that might support that rhetoric. But evaluation is going to put you on a realistic set of goals and a realistic time frame. And then from there, we jump into working together and we can really execute a plan going from phase 1, phase 2, phase 3. Okay. If you haven't seen my treatment planning lecture, go back to that. I mean, it would be very beneficial because then you'll know how you really could get from phase 1, 2, and 3. Okay. All right. So, referring, just how do you refer? Like, how do you self-refer? I would say defer to the provider and their process. There are some people who take phone calls and when they take the phone call, like that's them. You're talking to your myofunctional therapist. You take the phone call, and that right there is your consultation. So that might be why their next step is the evaluation, because they've talked to you, they've kind of talked it out, and they maybe have the time to do so. If you call the Myo spot, very rarely, if ever, are you going to speak to me. There's always somebody who's answering the phone or sometimes not answering the phone. And don't worry, we'll get into that in just a second. So there's always somebody who's there to answer and kind of field which way things go. Is this a consultation? Do we need to schedule that? Where can we schedule that? Carice has a lot of other stuff going on. Like, where can we put that in her calendar? And then how can they kind of fill me in on what exactly I need to know prior to that visit? The referral process for me, I'm always going to defer to like have them call or schedule online. Just schedule online. Like, don't even call and bother anybody with, answering your phone call. It is 2025. Like, are we still doing phone calls? People still use their cell phone for phone calls? I don't know. Is that a thing? Let me know in the chat. But for referrals, defer to that provider, because some people do want phone calls. I prefer that you just schedule a great time online. Like, just do that. But that's not everybody else's process. So here are some truths that I need you guys to absolutely positively understand. That way you can understand what happens when you refer someone. Okay. I need you to really grasp deep down in your soul how real this statement is, that many of the myofunctional therapy practitioners are solopreneurs, okay? And that goes across some various specialties. I've come across OTs that are solopreneurs. I've come across SLPs that are solopreneurs. I know many myofunctional therapists that are solopreneurs. And so, as a solopreneur, there are challenges there. Okay. New practitioners are going to require more time. Their consultations might be longer. They might be on the phone with you for an hour. They might be in a evaluation with you for like 2 hours. You're going to have to anticipate that you're going to spend some time with these people, particularly if they're newer. They just don't feel totally comfortable with their process, or they feel like they have to check every little box. I don't know. Whatever. It just requires more time. Don't worry, we're going to dive into each of these. And insurance is rarely an option. Like, please, please, please stop asking. It's very, very rarely an option. Sometimes it can be. Most times it's probably not. Okay. So let's go into independent practitioners. You have to be patient as a solopreneur. As a solopreneur, that means you're doing everything. I did a lot of everything for good bit of time in my business. And then my husband, like, everything kind of shifted in our lives. And my husband became really in depth into the Myo spot. So when you call the Myo spot, you get Harvey more often than not. You get my husband. And a lot of the people are communicating with him for scheduling, for appointments, for changes, for administrative. They need this, they need that. Like, all of that filters through him. I show up, I do the work. Like, I have to just be on and be ready and carry out the therapeutic process, which is fabulous, right? But as a solopreneur, if you don't have somebody else who's working for you, and sometimes people get VAs, and VAs are great, they can answer phone calls and so forth, but there's so much you have to teach to them in order to get them to where you want them to be. And then when you get them to that, there's still going to be things that they don't understand. I've been doing my spot for 8 years now, and in 8 years, there's still questions that Harvey doesn't feel totally comfortable answering, and that's okay. That's okay. There are questions I don't feel comfortable answering, but um, but essentially, you just have to have a lot of patience, okay? Because they're not always going to answer the phone. They might have a very long day where they're seeing clients, and then at the end of the day, they're going through all the voicemails. And so, okay, we got to write this down. All right, I have a list of people to call. Da, 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 da. And if they call you the next day and they didn't get you, or your voicemail is full, and then you wind up calling another therapist and you're like, oh, but I never got a call back. You probably did get a call back. I don't feel like most solopreneurs are not calling people back, because it's your bread and butter. You're trying to make business. And so not calling people back would be really wild. But if you called and you didn't leave a message, That's a problem. How am I supposed to know the difference as a solopreneur between a spam call and somebody who's calling legitimately if you don't leave a message to say, hi, I'm calling to inquire about myofunctional therapy. My name is Susan. Give me a call back whenever you get a chance. My number is. If you don't leave a message, you just assume I'm going to call back every number that dials. Do you have any idea how many spam calls come in for all sorts of lines of business? Particularly because one of my lines for my business is a cell phone. So it's on these random lists that get these phone calls, and they're asking me about my car's extended warranty or whatever. Like it can't always be that they're not answering the phone, but anticipate that there's going to be a bit of lag time between your messaging or your phone calls and getting return on such. Okay, be really really short on data with solopreneurs unless they're explicitly telling you, like, hey, let's do a consultation right now. I'd love to know what's going on. And then they really guide you into that. Otherwise, I don't need your whole life story to book a consultation where you're going to tell me your whole life story. Just really short. I was referred by such and such, or I found your Instagram such and such, and I would love to chat with you more about if myofunctional therapy is for me. Awesome. Really short on data. Solopreneurs are short on time. We're really trying our best to hit all of the aspects. You've got to be your own accountant sometimes. You've got to be your own bookkeeper. You've got to be your own administrator. You've got to be everything, the therapist. You have to be all the things. And to be all the things requires that people get really succinct and concise with the data and the information that they provide. And be flexible. They might still be working a whole nother job because maybe their practice has not gotten to full time yet. So if they're not full time yet and their only available appointment is at like 10 a.m. on a Tuesday, or it's at 7 p.m. on a Thursday, or whatever, you're just going to have to be flexible with what they have available. So many newer practitioners really don't draw those boundaries because you feel like every bit of business you want to grab and you want to get. And so you're saying to yourself, okay, they're only available at 4:30. I have to work. Maybe I can call out a little early, or maybe I'll just be off that day, or maybe I'll whatever, or maybe I'll have somebody else pick up my kid from school. You don't have to flex to everybody else's schedule. And that's the biggest way to burn out and to just hating the life that you're living as a myofunctional therapist. But you can allow people to be flexible with you. If I call into a specialist, if I want to see a cardiologist and the cardiologist has XYZ appointments open, guess where I have to figure out where I can move my schedule to fit into where they are. So myofunctional therapy is its own little specialty. There's not a lot of us. You're going to have to be flexible. It can't always work in with your schedule as a patient. So be flexible with the providers. Okay. And that's something really important. Newer practitioners requiring time, even some veterans require time. Some of them like a good 1.5, 2 hours, 2.5 hour evaluations. If they require that much time, give them that much time. Like, that's what they want. So you're gonna have to spend time with them. All of my evaluations are roughly an hour, and if I can get out earlier than that, then yes, Lord. If I could save 30 minutes, I'm gonna save an hour. Like, I'm trying to save here as much as I can, time and money. It's important, I think, for all parties involved. So, you know, just be patient because evaluations can take time, and particularly with the time after the evaluation. I used to do reports in 24 hours, and then I've gotten so busy that I pushed it to 48 hours. And I really wish I could push it to, like, I need 72 hours, but that just feels like too much. And so I'll be up in the middle of the night and I'm like doing all these reports and trying to get things together. But you're gonna just have to be patient. When they can get the report to you is when they can get the report to you, okay? I love details on my report. It is very rarely that I send something that is less than 7 pages. Well, I'm going to say 5 to 7 pages, less than 5 to 7 pages in duration. I like to write it out. I want you to be able to see very distinctly, very clearly where I got this information. This is what's going on. I don't like a bullet list report. I don't like a report that's just like, I found this. Okay. Like, what does that mean? Who cares that you found this, and this? put it together for me. Okay. So I put everything together with the report. It's very much what I found, and then our realistic goals. And based upon what sort of research, I have citations in there. Like, how can we get there? I have that written out in a whole treatment plan. This is what I found. This is what, we need to do. These are my suggestions. This is why I'm making this recommendation. And then you're able to get from there what you need. If you are not satisfied with what you have received or you don't understand it, be curious. Ask questions. Ask many questions. So I have a lot of people who have my personal phone number, and it's good and it's bad. I'm happy to talk to people at any point in time about Myo. It's my passion, it's my purpose, and I love to help people guide their way through. In fact, I have two specific families that I'm kind of back and forth on calls with. Now, neither one of those families have signed their treatment plan, but I know in the future they will work and we'll do Myo. But they're trying to navigate airway centered dentistry. They're trying to navigate treatment plans that they've been given from providers who are supposed to do expansive procedures. They're trying to understand why they don't have certain metrics. Like, after seeing my report, wait, how come I didn't get this from the doctor that charged me 3 times what you're charging me? And I don't know what's going on with them. Well, because it's a wild, wild west. Okay. So you're going to have to be curious. You're going to have to ask as many questions as possible. There's no standardization in the field. There's no one place to study. There's no dental school that's really teaching this the way it should be taught. Dental sleep medicine is an entirely different beast. But like all the different appliances that are out there, anybody can go and take a course, can start doing an appliance, and you have no idea how it's working. You don't know if they're being led by the company, like if there's any sort of tracking or tracing or, treatment projection. You don't know. They could just be kind of winging it, just kind of learning as they're going with you. And that is totally fine. Everybody's got to start somewhere, but be curious. Ask the questions that'll get you these kinds of answers. So, what kind of questions? That's what I'm between with these two families. What kind of questions should they be asking? What kind of information should they be looking for? How should they be interpreting certain things that they've gotten? And then from there, they're starting to really open their eyes to the process. So any questions that you have about a report, your myofunctional therapist should be able to answer very, very clearly about this report, where we got this information for, what this information is about, what are the projected outcomes, how is it that we're getting to these projected outcomes. Like, be curious. Okay, so newer practitioners require time, and challenging them on what they've found and so forth is only going to make them better. Okay. Insurance, rarely an option. A lot of times it's not an option for, anything outside of speech language pathologists, physical therapists, occupational therapists. Okay. A lot of times that's not a part of the deal. And that's okay. It's okay. We pay out of pocket for a lot of things. I sometimes say the whole analogy of like, 15 years ago, was anybody talking about lactation consulting? I certainly don't remember it as a thing. I have a 21-year-old. He just turned 21 this week. I remember struggling to breastfeed him, and it was not an option for me to go and like see a lactation consultant who would come to my home. Not to say that that didn't exist, right? Not saying it didn't exist, but who would come to my home and it would be taken care of with insurance. Like, the hospital didn't tell me that was a thing. My mother works in labor and delivery, and she did at the time. She's retired, but she did at the time work in labor and delivery, and knew a lot of lactation consultants and never knew that that was a thing. So we failed at breastfeeding because we didn't have that as an option. So if you look back 15 years ago, I don't even think that was an option, or if it was an option, it wasn't a very common, well-known, popular option. And here we are today, and everybody knows that's an option, and it's a pretty prominent option, and everybody's always offering those options. My youngest is 10. I was offered that as an option when she was younger, but we were breastfeeding relatively successfully. It wasn't, whatever, that's neither here nor there. But it was a transition. Myo may get there. Chiropractic wasn't always there. That wasn't something that was always covered. By the way, still a pseudoscience, and now it's covered by insurance. So it's okay. It's okay for these things to take time. Allow the process to happen. So it's rarely an option now. Be prepared to pay out of pocket. If you have health savings accounts or flex spending, like that might be an option for you. But more often than not, anticipate coming out of pocket for myofunctional therapy. So if you are somebody who's referring, don't suggest that they ask their myofunctional therapist about insurance. I would rather you prep them for insurance is likely not an option. You can ask, but it's likely not an option. Anticipate paying out of pocket. Okay. Just because you refer or just because you were referred, it doesn't mean that myo is the next best step. And it's interesting because I got this slide, or like the idea to talk about this slide, from my husband, Harvey. I said, when people call, like, what's the one thing that you would really like them to know? Probably that they should know what myofunctional therapy is. And just because they were referred doesn't mean that that's what they need to do next. And I'm like, that's genius. Like, only somebody who's answering the phone would come up with that, because I'm talking to them after they've already talked to him. And he's like, look, she might tell you that bio's not the next thing that you're going to do. So, referral. When you're referring, you might see things. You might see a lot of things. It could look like all the red flags in the world and that they need nothing more than a myofunctional therapist, right? Like we need to jump skip into myo yesterday. But just because you're referring, just because you see those red flags, just because I might see them on a consultation, doesn't mean that myo is where we're going next. It doesn't mean that I'm going to jump into an evaluation next. Sometimes an evaluation might be needed to understand and determine if that's the next step, if that's where we're going next. But it's not necessarily the thing that determines that, yes, okay, you've been referred, you're getting myo. So I don't jump straight into evaluations for that reason. Like I stated earlier with the consultation, there's a lot of other factors and things that might stand in the way that say, hey, you need to go see this person next, or you need to do that next. And then call me after. Call me in a year. Call me in 2 months after you've completed XYZ. Like, call me after that point. So I thought that that was a good one. It's a great way to make people feel more confident when they are calling. And I think that's the number one thing. If you're a referring provider or you're somebody who's being referred, you don't want to be on the phone confused. You don't want to leave a consultation confused. You don't want to not know. And so do a little bit of research, a little bit. Some of what's available online about myofunctional therapy is really questionable in content and in quality and in factuality. Like it's a mess. But I think it's really important to approach it from a little bit of a heads up. I love to give a good heads up when I can give a heads up that myo might not be the next best thing, and they'll be grateful for it. And a lot of those people you'll see back again. Okay. So what are we looking for? You're like, I've referred them. Like, what is it that you're even looking for? Why am I sending these people to you? We're looking for all these things, and I'll break them down in a little bit, but we're essentially looking at all these things. And I hope that it's as comprehensive as it could be, but for the most part, I think so. Existing patterns of function, and that's going to display any sort of dysfunction. If their function is not adequately functional, that's dysfunction. So existing patterns of function and the orofacial, pharyngeal, and oral spaces, okay? Muscular dysfunction, any sort of recruitment or compensatory patterns, parafunctional habits, tethered oral tissues, which I have a soapbox that we're going to stand on for just a hot minute, okay? Underdevelopment of musculature, overdevelopment of musculature, asymmetry of musculature. Like we're going to figure out and kind of work through all of these things in an evaluation. If you are really one lucky ducky, you're going to find that you might have an evaluation. Like I do 60-minute myofunctional evaluations that do include cranial nerve dysfunction. And then if I find that, I have to now look at, okay, are there any primitive reflexes that I have to work on? What's going on with their chakras? And we do look at some of the vagal tone. That these are just some bonus things that I look at, and some bonus things that like people that I teach in my courses might look at, or like people who are, seasoned in other things might look at. There's other things to look at as well. And so it's not just the orofacial function or dysfunction that we're looking at. There are other things we might be looking at as well. And so if you're a lucky ducky, you might wind up with a myofunctional therapist in your area, or, who you call, who's looking at other things too, and might be able to work with you on those other things and integration of some of these other things as well. Okay. All right. Now I'm going to get on my soapbox for a quick minute before we transition over to deep dive into the evaluation. Tethered oral tissues. In one of the Facebook groups, I don't know which one it is, but I'm in a lot of dental hygiene groups. There was somebody who posted, like, how do we know what to look for in a posterior tie? And then, like, the comments then go into, like, floor of mouth and hold down floor of mouth, which, by the way, is a contested view. Okay. There is no standardization. There's inter-rater reliability on floor of mouth thing is, first of all, a farce. Like, it does not exist. And so we need to stop saying it like it's a standardized way to look at a frenum. It's not. And that's okay. That is absolutely okay. Outside of that, the next thing is that we don't call it a posterior tie. We call it a mid-tongue restriction. I don't care what you're calling it. What you need to call it is a structural appearance. You're not looking at the function. Many times people aren't looking at any functions other than elevation. There's a lot of functions of the tongue, and particularly mid-tongue, that would need to be looked at and evaluated to see, is this restrictive? Because there are people, surprise, there are people who don't have adequate tongue function or are unable to function appropriately with their range of motion or establish the different shapes and purposes of the tongue that don't have ties. So surprise, there's going to be people who have ties that are able to function without compensations, or you can remove the compensations from, and they can function adequately. Because guess what? Not everybody wants to have a surgical procedure. And we need to stop talking as functional providers, myofunctional therapists, as dentists, as whatever. Like, we are getting slaughtered, absolutely slaughtered in the media, because everybody looks at a tongue tie as like, oh, you have a tie, we have to release it. And immediately we start looking at releasing and letting things go. It's a cosmetic procedure. The alteration of a frenum or the removal of such frenum does not inherently change function. Oh my gosh, you've got that frenum removed. Now all of a sudden you're able to do all of the tasks. Like, who needs myofunctional therapy? Like, who needs that? Who needs lactation? You just remove the frenum, duh. Like, that's it. Why would we need to do more than that? Because it's cosmetic in nature. You've removed a bit of tissue. What has inherently changed about the way those tissues that were attached function? Nothing. You need a functional provider. Whether that's working with a baby and it's a lactation consultant or a feeding therapist, or it's working with, an older child or adult, and you need a myofunctional therapist, you need some therapeutic intervention. No doctor in the world is just slicing off bits of tissue in other parts of the body and telling you that you don't need any physical therapy, because they respect their process and their outcomes more than to do that. And in dentistry, we seem to just be like, oh, no, we don't respect our processes at all. We could see a tie and just release it and all will be well. We'll give them a couple of exercises and they'll be good. No, that's not what the root cause of the dysfunction was. And so you need to have somebody who can actually look at the function, okay, and to assess if this is something that is restrictive of function. And if it's restrictive of function, are you able to remediate that with a therapeutic process? And if you don't have answers to these questions, stop looking for posterior ties. If you suspect something, or you're hearing enough red flags, or you go through a screener like Brooms that's going to give you that kind of assessment, then yay. If you are suspicious, refer. A myofunctional therapist is really always the best start, because you're never just going to jump into tongue tie release. You're never just going to jump into lip or buccal tie release. You're always going to send them out so that they can have some functional work and prep before any of that happens. So let's start thinking about it in that way. Okay. So, yes, you can refer people for tongue ties, for lip ties, for buckle ties, for whatever frenum restrictions you feel like exist. You can refer. Let's start doing that a little bit more. I should check these comments because I don't know. I get a little bit like, and I like get a little bit elevated or whatever, animated. I should say animated. Hey guys, hey. No phone calls for Lindsay. That's funny. Oh my gosh, you guys are hilarious. Okay, now it's time to shift because I think I've been doing this hand movement enough already. Now it's time to shift. Okay, we're gonna shift gears. Now we're going into like the myofunctional aspect of things. So, as a myofunctional therapist, what are we looking for? Surprise, surprise, it's the same list, same slide. We're looking for the same stuff. But now we're going to dive a little deeper into like, what does all of this even mean? What exactly are we looking for? And then here's the better question. Why are you looking for it? If you don't know why you're looking for it, if you don't know how to isolate remediation and the process of such into these specific categories, why are you looking for things that you don't even know how to remediate independently or personalized way? If you're doing a cookie cutter program, if you're doing something that is just like, visit one, visit two, and like everybody gets the same thing, stop doing evaluations. You're wasting people's time and you're wasting your own time as well, but you're wasting people's money. Sorry, you're wasting people's money and you're wasting your own time because you're not going to do anything about these things. You assume that all people can do the exact same thing and get the same outcomes. So why does it matter how they start? You assume everybody's going to end up in the same spot because you're giving them the same sheets of exercises and giving them the same routine. So you don't need to do an evaluation. And then we could just like streamline. Yay, I saved you a lot of time and effort, right? Yay. What I really would like you to do is go back to my treatment planning lecture and to like really get deep in on that, okay? Existing patterns of function. So when we're looking for existing patterns of function, we're looking at things in real time. And that's what I like to tell people. So I do home visits. I do mobile therapy. I go to the home. I will see people in their home. When you come into a clinical environment, we're already a little bit walls up and more performative in nature. As a dental professional, I can't tell you how many times people will tell me, yes, I'm doing all the things I'm supposed to do. I floss every day. I floss twice a day. And then you look at their gums and their gums start bleeding. And you're like, yeah, you do. You do floss every day. Twice a day? Girl, you look like you floss 3 times a day. What? And we know it's all performative, right? They're putting on a show because they want the better outcome. We all do. We all want to be told that we're great. We all want to see that other people can see the beauty and the value in us, right? So when I talk about evaluations and I do it in home, it's to make things as comfortable as possible. Like I'm entering your space. If anybody should have a wall up, it should be me. But I come in and I'm comfortable and you're already there and you're comfortable. This is your space. So everything is going to be kind of walls down, guards down, and more natural. And I can see in real time how things actually look, how things actually present, how you actually sit in a chair. Like it is your dining chair, it is your couch, it's your whatever. Like how do you actually sit in it? Are you sitting with like a slouch? Are you sitting with like some rolled posture? Like how are you actually sitting? I'm able to assess the posture and whatever. So you don't have to do things in people's homes. You can make them comfortable in your space. I would say when I do see them in a clinical environment, because there are some people I will go to a dental office and I will see, or I will go a certain place and I will see them. If I am looking at you and we're in an environment that you're not comfortable in, I'm going to make you comfortable. Like, let's chat. We're going to start out just nice and easy. We're going to chat and we're going to chill. And I'm going to kind of get a little bit more background, maybe dive a little deeper into some things. And we'll have a conversation first. And then things, as you start to loosen up and you become more comfortable, and I've cracked a couple of jokes and we're feeling really good about each other. Awesome. Now things are more natural. So make it as natural or an environment as it can be when time allows. and with as much, ability that you have within your own personal nature and so forth, that you can make it comfortable. Because when we're looking at these things and we're assessing function, we want it to be natural. So their posture, I look at the gait. The gait is their walk. So I always ask people to walk. I would love to see you walk. Like, just walk from one end of the room to the other and then come right on back. Don't look at me. Pretend I'm not here. Walk as you normally would. Some people are looking down at their feet the whole time. I'm like, that's not, do you always walk with, you have to watch your feet to see where you're going? Like, is that what you do? No. Okay, well, give me a normal, natural walk. Like, how do you really walk? Just walk like you're walking to where your car, you're walking to the school bus, you're walking to somewhere. Walk like that. And just let me say. And then we can see the posture. We can see if there's any forward head posture. We can see the oral rest posture. We can see what's going on with the breathing. I always ask them to take a deep breath. My 1 minute breath test. Take deep breath in through your nose. We're going to sit down on the chair, feet planted flat on the ground. I want you to sit up with as good posture as you can muster, and get a deep breath in through your nose. You're going to breathe in through your nose, out through your nose, because everybody's real quick to open up their lips. Out through your nose. In through your nose, out through your nose. I want you to do it 3 more times. As you're doing it, I'm going to talk. So keep doing it. A lot of people stop, but keep going 3 more times. As you are breathing in and out, I want you to just get really introspective. And I get really low in my tone. Get really introspective. And I want you to feel where your tongue is in your mouth. Feel where your teeth are in your mouth. Are your teeth together? Are they apart? Is your tongue high, middle, low? Is it kind of undiscernible? It just feels like it's kind of floating in space. What are you feeling? They typically come off of that third one, maybe 30 seconds after that. And then they're telling me, okay, well, I feel my teeth are together, or my teeth are slightly apart. My tongue is here, there, or wherever, whatever. So you're able to assess where their oral rest posture is. As they get more and more comfortable, the last thing I'm checking off is the lip posture, because that's going to be as normal as it is after we've been sitting together for an hour. So if 80% of the time the lips were closed, I assume you have predominant lip closed posture, especially if there was no strain. I don't see any orofacial or any mentalis, like there's no strain on the musculature while you are closing your lips. I'm going to assume that 80% of the time your lips are closed. And then I'm going to ask you to verify most of the time, mouth open or closed when you're breathing. And they'll tell you. Most people who are honest, or the parents will tell you for sure about the children. Looking at them and their movement, I'm always assessing for balance, and looking at how they move and how they manipulate their bodies, when they turn, when they lift, when they drop. Like, how is movement? Is there any restrictions? Is there any asymmetries in that movement? Mastication, is it unilateral? Is it bilateral? Do they have rotary movement? Or is it more of a munch? Are they just, okay, if that's how you eat, that's how you eat. But now I know, red flag, there's some things we might need to work on, or some referrals I might need to make, one of the two. Swallowing, the oral phase of the swallow is the only thing assessed by a myofunctional therapist. I'm just going to say that, and I'm going to move on from that whole swallowing conversation. Muscular dysfunction. When we're looking for muscular dysfunction, this is when we're taking all of those functional patterns and we're really saying within normal limits or no. If it's not, then what's going wrong? Those are the compensatory patterns. Where are they recruiting other muscles? If they are doing a swallow and the cheeks are retracted and the tongue is pushing forward and there's mandibular retraction, and I know there's compressing of the joint on the temporomandibular joint, when I go and I feel on the joint, am I feeling any crepitus? Is there any deviation or deflection? Like, what's happening there? Where's dysfunction that accompanies that? Master activation, is it weak? Is it strong? Is it more on one side? If it was unilateral chewing, what am I anticipating to see? Am I expecting to see a more prominent feature of musculature on the side that they're not chewing on, because those muscles are more flaccid, and the other muscles would be more strong and more, engaged and more of their normal functioning, whereas asymmetrically, what I would expect is more underdevelopment of the muscles there. Is there lip pursing when they swallow? So the tongue is pushing forward, and everything that's falling forward, the lips are having to pull back. And so the lips are pulling in, and you're getting that anterior suction that's trying to push back some of that saliva, food, whatever that is pushing forward with the tongue. Like, what are we looking at? So muscular dysfunction is what we're going for. Where is all of the recruitment or compensations? What do we have to target and eliminate? If anything, they might come out, with flying colors and just a few things wrong. Parafunctional habits. What habits are existing and what do we have to try to eliminate, or essentially try to, reduce? Because not everything can be eliminated. Bruxism, I'd say, is a big one that, like, sometimes we all want to eliminate bruxism. There's multi-factors, it's multifactorial as to how bruxism occurs. And so, with that and our understanding of such, we have to be very, very aware that bruxism might be just reduced in a myofunctional therapy program. Whereas, like, object sucking, tongue sucking, lip chewing, lip biting, cheek biting, like some of those other things, we know we can eliminate. We know we can get rid of mouth breathing. We know we can stop the tongue sucking. We know we can get through the cheek biting and so forth. Like, we can establish a harmonious balance of the soft tissue and the functions of such and the pressures of such to get to a point where these parafunctional habits aren't a thing. But we have to assess, what is it that we have to work on? And then how do we get there? Okay. Awesome. Tactile observations. Please let me know in the chat if I am losing anyone at any point in time. Okay. Tactile observations. So we're also going to do a tactile portion. And I always tell people this is like the shortest portion of the exam. Most of the time, I am really observing you and watching you in your function, even as you're just talking to me, like, what's happening. I'm watching your jaw. I'm looking at how you move. I'm watching how everything is really playing out. But the smaller portion of it, I'm going to take some measurements. I'm going to feel some musculature. We're going to get in there. We're going to kind of see what's going on. I'm going to get my hands intraoral. I always tell you where I'm going before I do. Can I feel the inside of your cheeks? Yes. Okay. And I do that motion. That way they kind of know, like, what's coming. Like, it's going to be feeling the inside of your cheeks, just like that. Can I feel? I always do it with one finger. So I'm like, can I feel your palate? So you kind of know what's coming. I'm going to do this kind of motion along the palate. So everybody kind of knows what to expect. But the tactile portion of it is always like the shortest portion, because I want to know function. I definitely want to know if there's any tension, any pain, any strains, any sort of muscular development that I can feel a difference of. Do I feel a prominence or a lack of prominence of a musculature? I want to know that. However, I also want to know the function, because the function is what I'm really working on, the function. And then when I feel again at the end of all of my programs, I do the evaluation all the way over. And so at the end of that, I want to know, like, am I feeling what I think I'm feeling? Are we better, or are we still off of where we should be? Okay. Photographs. When possible, I think it's really best if you can record your sessions. That's really hard for me to do. I'm mobile. I'm sometimes late to places because of whatever traffic or whatever. Like, I'm not setting up a tripod and, recording in different spots in people's homes. Sometimes the lighting's not always great for that. So I don't always do it. But you get a lot of great information because you can go back and watch that video, and then things you may have missed, you'll get. And then you can always take stills at just the right moment. So you can stop, pause the video, and then screenshot it. And then you have now a photo of exactly what it is that you're trying to describe, or exactly what it is that you want to display, or exactly what it is that you're looking to remediate. And then you can go from there and, comparatively do pictures at the end of a program or throughout the program if that's what you do. But at a bare minimum, you want to be taking some photos. Bare minimum is photos of occlusion, posture, facial profile, side profile. A lot of times that might be all that I really get to. But Other desired photos that you might want to take is some of the frenums, especially if they're restrictive in nature. Take some of the frenums. I do video as well. So I'll do an isolated video. I'll ask for some function. We'll have cheek retractors in, and I'll ask for a swallow so I can see what's going on in that oral phase. Is liquid coming forward? Is the mandible retracting? Am I getting the tongue pushing out? Is there an open bite? Can I see the tongue pushing through? Is there spacing between the teeth? Then I can see the tongue wherever it is. We're able to see what's going on. So videos I will take as well. But other desired photos of the frenums, the tongue and the tongue function. Sometimes I'll do a video of such. Can you suction for me? Can you, retract the tongue? Can you elevate it? Can you hump it? Can you make a taco? Can you make a bowl? Can you whatever, lateralize? Like, can you do all these things? And then from there, I'm able to now make a comparative video and so forth. So you could also do that as well instead of taking photos. But the nostrils, when you have them up, is their nostrils when they tilt their chin up. Nostrils, some people also do that as a postural or a functional photo. So with the chin up, and then post myo, how far can your chin elevate up, and then how far can you go down, and so forth, and the comfort of which you do so. So photographs, that's also something that you want to get done too. Okay, so your review is the very, very end. I hope nobody skips this step and just kind of dismisses them like, all right, we finished your evaluation. I'll have your report and, bye. I'm going to assume most people are actually getting into the nitty gritty. I do some highlighting of findings. So I tell them 48 hours, you're going to get your report and your treatment plan. It'll come in your email inbox. It comes from our secure signing service. Once you sign, we contact and reach out to you, and we start getting you on schedule. And so we're going to get you set up. What we always offer you to do is to reach out with any questions. So don't sign if you're not want to move forward, or if you just don't understand and you want to have a conversation. We'll book another consultation and we will go over all the findings. That way you comprehensively understand. But here are the highlights of what I found. So I'm going to take my evaluation sheet. I don't think there's anything of any importance here, so I'm just going to hold it like that. But I would take my little evaluation sheet, and I'm going to go through it, and I'm going to say, okay, so I found such and such, such and such, such and such. This is a problem because of this. This is a problem because of this. This is probably why you're experiencing this. And, these are some of the big things that you're going to see in the report. As far as our realistic goals, looking from a very brief glance right now, because I'm going to sit down and I'm going to digest this information, looking at a very brief glance right now. Here's what I see. Here's what I suspect is going on. And I think my next steps are, I'm definitely going to recommend a myofunctional therapy program, and then a release. And then we're going to continue our myofunctional therapy program. In between, I need you to see a manual therapist. After that, then, whatever, we're going to go through all the things, whether that's some ortho in there or dental procedures, or there's a surgical procedure in there. Like, we're going to go through all the things. That way they have an expectation of what they're going to see, and it correlates more of what they're reading to their memory of, oh yeah, 2 days ago she did tell me that. Oh yeah. Oh yeah. Oh yeah. And then I confirm what the next steps are. Okay, so you're getting your report, 48 hours. Check your spam junk box if you don't see it. We always text. Harvey always sends a great message. He's like, hey, your report was sent by Carice. Just let me know if you have any questions. Happy to book another call. Awesome, I got it. Or no, I didn't see it. Did you check your spam box? Yes. Oh, great. That's where it is. It's in your spam box. Okay, so just check there. All right. So you've reviewed, you've recapped, and honestly, you have to do something with this information now, right? So now you have your time where you need to sit down and really digest this. So yes, you're doing the evaluation so that you can write a great report and you can propose a treatment plan, but you also need to execute this treatment plan. And so you need to understand why you're doing it. Like, why am I looking at muscular dysfunction, compensations, parafunctional habits? Like, why am I looking at that? what is it that I'm going to be able to do with this information? There is a purpose. It is not without a purpose. And if you are stuck, treatment planning, it is the next best step. This month has been absolutely hectic for me. It's been wild, an absolutely wild month. My birthday is coming up very soon. And so, I'm struggling a little bit. At the end of that one, I promised to review treatment planning with everybody, and I still will do that. It'll likely be beginning of April. So you can always email me if you really have no idea what you're doing and you're like, I don't know what to do with this information. We'll go through treatment planning and I'll have you kind of treatment plan with me. We'll kind of do it live. It'll be a nice, fun Zoom thing for everybody to do. So you can email me. I'm hello@the I'll put that there in the chat somewhere or whatever. But let me go back. Let me see if there are any questions. Jackie likes how I assessed oral rest posture. Thanks. I like it too. Dr. Pena, I think this was really good. It's exciting to see how collaboration can lead to better patient outcomes. Yes, I love that. That is a really good insight. Thank you, Dr. Pena. Awesome. What is lip hooking? That is a great question, Jackie. Thank you. Lip hooking is a trapping of the lip behind. I don't even know if you could see this. So let me switch this up. Maybe I could highlight myself or just remove this. Let me remove that for a second. Yeah. Does that make me bigger? No, it does not. Oh my gosh. Okay, here we go. There you go. A trapping of the lip. They just hook it behind their teeth. And so it just sits there. It's like a parafunctional habit that doesn't involve any sucking. They're not sucking on it. It just sits there. Now you can combine lip hooking with lip sucking and also with lip licking, but it's not always as such. It doesn't always come off as such. Okay. Awesome. All right. If there are no other questions, it's been absolutely fabulous being here with you today. I was supposed to give you guys my email address again. I'll give that to you. It's hello, HELLO, at themyospot.com. So THEMYOSPOT.com. If you want to sit in on that treatment planning session. I have not responded to any of the emails, guys. So forgive me if you wanted to sit on that section and you're like, hey, I never got any emails because I haven't responded to those. I haven't even started planning it, but it'll be in April. Okay. And if you want to chat otherwise, happy to chat with you. My link to chat is there. Look forward to seeing you guys next week. Have a fabulous weekend. Bye, friends.